Good afternoon, everyone. I am so sorry I'm not there with you for the conference this week, but I really wanted to take this opportunity to share with you some emerging thinking about the role of health and care systems in England to really pull it all together to make meaningful impact in tackling racial and ethnic health disparities. And what I'll be doing today is both reviewing our recent experience of going through the pandemic and lessons learned, but how do we pull the various strands of initiatives together so that we can make meaningful action on this most pressing of public health issues. Now, it was Martin Luther King Jr. who said that of all the forms of inequality, injustice in healthcare is the most shocking and the most inhumane. And sometimes, even although we know and we love the NHS here in the United Kingdom and in England, it is a universal health service, but it does not necessarily serve everyone equally. And our experience of the pandemic has really shown how those inequalities manifest themselves and ultimately the impact of those inequalities. So let's review some of the key lessons from the pandemic and what we've seen over the past 2.5 years with COVID-19 and its impact on racial and ethnic health disparities. The first is a real understanding that these inequalities drive morbidity and mortality, that the impact of the COVID-19 pandemic was felt most severely among those in our society who are either social and economically disadvantaged, excluded from society, disengaged, or least trustful. And that impact of the pandemic, of COVID infections, of mortality, as well as the consequences of COVID, certainly has widened over the past 2.5 years. We know that people who and communities that entered the pandemic with long-standing inequalities were more likely to experience the disadvantages and the impacts of COVID-19. And in that sense, these inequalities are both pervasive and persistent. And COVID-19 has in fact widened inequalities due to its direct and indirect impacts on disadvantaged communities across the country and around the world. Thirdly, because of our experience of going through the pandemic and seeing and feeling the nature and the rapidity and impact of the inequalities on our communities, we now know better. And when we know better, we must do better. And so, emerging from the pandemic, it is fantastic to see the range of initiatives now being implemented, the clarion call for us to tackle inequalities as part of the recovery post-pandemic, and the range of actions currently being undertaken. And now is the time for us to begin to think about impactful action, which is coordinated at local level, sub-regional, regional, and national level for greatest impact. And we have to do that with the urgency of now, recognizing that we do not and cannot delay action on inequalities until recovery programs are complete. But instead, inequalities should be the lens through which we are delivering and designing our recovery programs in order to build back better and build back fairer. And a key part of this is understanding the lessons from the pandemic and creating new legacies. Legacies that build upon experiences of using effective data and insights capabilities that we developed through the pandemic. The fantastic multi-sectoral and multi-level partnerships that took us through the pandemic form the basis of tackling racial and ethnic health disparities. And of course, because we had to deal with so many of the social and structural drivers of COVID and subsequently other health conditions, we now have the opportunity to build upon those lessons and create new legacies for health and care systems. Now, health and care systems are often seen as only contributing a small part to what generates health overall in any society, and that is true. We know that other factors, including social circumstances, environmental exposures, and health behaviors, can account for a larger proportion of what actually creates health and what may drive health inequalities within our society. But that doesn't mean that healthcare systems do not have an important and unique role to play. And I would argue that certainly in England, as we're going through significant transformation of our health and care system, now more than ever, we need to firmly clarify and articulate what role healthcare systems have in tackling health disparities. And this is important because failure to do so will result in organizations feeling that this agenda is too big, that this agenda is too large or too difficult to tackle, and this can lead to a state of learned helplessness. And as highlighted on this slide, learned helplessness is not just an individual psychological phenomenon, but it's seen in organizational theory and behavior. It is the giving up reaction, it's the quitting response that follows from the belief that whatever one does, whatever the organization does, doesn't really matter. And this can truly affect the progress, the change, the transformation, and the innovation in tackling racial and ethnic disparities that we would like to see our health and care systems do today. And we've all recognized this and we've all seen this, right? So in our organizations, when we hear our leaders or team members shut down efforts to tackle inequalities by saying things such as, it's not going to work, or it is so complex, I don't know where to begin, that's not going to get improved, or we wouldn't bother because it hasn't worked in the past. Or one of my favorites is, Kevin, just tell me the one thing that we need to do as an organization to tackle inequalities. So these are ways in which organizations can sometimes feel overwhelmed by the agenda. And I think one of the things that we must do coming out of the pandemic is provide clarity to what we're asking our organizations and our leaders to do. Now, organizational and management literature provides some insights into what can be done to tackle learned helplessness in organizations. And there are two key pillars of that response. First, shine a light on the behaviors that characterize that learned helplessness. And second, unleash the power of your organization to act on that particular issue. So in shining a spotlight on the problem, call out the behavior of learned helplessness, identify what are some of the recurring patterns of behaviors that are seen in an organization that prevent people from actually breaking through barriers and doing what is right. Understand when initiatives have failed in the past and ask why they have failed, and put together a list, for example, of the top 10 excuses that people are giving for not really doing what they know is the right things to be done when it comes to tackling these racial and ethnic health disparities. And second, we can unleash the power of our organizations through leadership, leading, setting expectations, holding their organizations to account, setting the pace and the vision, as well as the outcomes that they want to see in tackling health disparities. Now, we've been thinking in London about how we pull together all of the various strands of work which is being done on health inequalities in place so that we have a cohesive framework that helps us for organizations in health and care systems to tackle racial and ethnic health inequalities. And there are 5 components of this framework which are based upon 3 foundational requirements for organizations. So the first is that we need our organizations and leadership of organizations to take a very strong stand on being anti-racist, that there is zero tolerance for racial and ethnic discrimination, and in fact all forms of discrimination within their organization, and that there are HR policies and programs and metrics in place to understand the experience of the employees as well as communities and the journey and the progress that their organization is making on becoming anti-racist. Second, that there's visible support for Black, Asian, minority ethnic staff through the implementation of robust equality, diversity, inclusion initiatives and HR workforce policies, so that you're providing good work for all of your employees and fair opportunities for all. One of the things we learned throughout the pandemic was local communities say, if you do not treat your own Black, Asian, and minority ethnic staff well, why should we trust you to treat us in the community well also? Third, Target your efforts in the most impactful programs for tackling health inequalities. We're not asking organizations to do everything overnight, but what we are asking you to do is to identify a framework that should guide your actions, prioritize the programs, and to ensure that you're delivering on those priorities so that you can demonstrate success. So for the NHS, this may be the Core 20+5 initiative, which gives NHS providers a clear sense of what should be prioritized. For those working in local government, we can use the Marmot principles, priorities that arise from health and well-being strategies and action plans. There's so many frameworks and priorities. Choose a few, focus on what's effective and based on evidence, and build with communities to tackle those inequalities. Fourth, become an anchor institution. Understand the financial, social, cultural, and transformative power that your organization has, and be part of systems, other systems which are also being anchor institutions as well. And finally, the fifth and most important pillar of this framework is rebuilding local trust and confidence in health and care services. And we've learned about the power of re-engaging and empowering communities to be part of the response. And that must be taken forward by all health and care systems moving forward. And this is about building on the assets within local communities and leveraging them for greater engagement in their own health outcomes. So these are the 5 pillars, and there are 3 key principles or foundations which should underpin these within our organizations. We're asking for robust governance, that there's good executive leadership and championing for tackling health inequalities, that there's good accountability within organizations, and that delivery on equity outcomes are as important as clinical indicators and other indicators which are important and measured in health and care systems. That there's good data that underpins your work, and so you're able to monitor your progress and evaluate your impact. And third, ensuring that you're not doing this alone, working closely and effectively with many of your local partnerships and bringing in diverse voices to help to challenge and shape your strategy on tackling inequalities. Finally, I think there are questions that we must ask of our leaders of health and care systems as we move on this journey to tackle racial and ethnic health disparities. And there are 6 key questions which I've had here for us all as leaders. We need to ask those difficult questions and have those difficult conversations to get to the root of the problem. And a key part of this is challenging all assumptions and not listening to the narrative of learned helplessness. We must ask team members to take ownership of problems and to be accountable for finding solutions through partnerships and with local communities, not by themselves. And we must reward behaviors that challenge the status quo, that helps us to break through some of the barriers organizationally or psychologically that we set ourselves in not being able to deliver on what is a challenging agenda. We must share the stories of successful change across organizations to break through silos, and we must set an example as leaders of avoiding that self-defeating negative thoughts and thoughts that lead to helpless behaviors. And that's a key role for us all as leaders. So in closing, it was the Supreme Court U.S. Justice Felix Frankfurter who said, "It is a wise man who has said there's no greater inequality than the equal treatment of unequals." And this perhaps is words of wisdom for us as we think about, in an environment where we do have a universal healthcare system, how do we ensure that it works for everyone? So I hope that reflecting on the lessons from the pandemic, thinking about a framework for how we pull it all together in place, and finally thinking about what we're asking all of us as leaders to do will help us to continue to address the big challenges of our time and really make progress on tackling racial and ethnic health disparities. Thank you so much.
Thank you. And I think probably from all of us here, we'd like to say congratulations to Kevin, because actually he has been fantastic and has done a stonking job for all of us throughout the whole of the pandemic. So thank you from everybody here, Kevin. And I think now, a little clap there for you, Kevin. Thank you. Okay. moving on, I'm going to introduce Sam, who you've seen already. Sam is the policy lead at the observatory, and he's going to be leading this next session, which will be a discussion. So I'll say no more and let you introduce your panel. Thank you, Sam.
Thanks. Thank you, Yvonne. So obviously, in an ideal world, Kevin Fenton will be here to chair this panel himself. Kevin Fenton, CBE, I should say. But I've been given the frankly impossible task of filling his shoes. So I will do my absolute best and invite the panel to join me on the stage. Thanks very much. So to introduce the panel then, you'll know him by now, our host, Professor David R. Williams, Chair of the Department of Social and Behavioral Sciences at Harvard's T. Chan School of Public Health. Likewise, Dr. Janet Smylie, the Director of the Well Living House Janet Smylie Action Research Centre for Indigenous Infant, Child and Family Health and Wellbeing. And I'd like to welcome to the stage Dr. Jeanelle de Gruchy, England's Deputy Chief Medical Officer and co-lead of the Office for Health Improvement and Disparities. And last but not least, Reginald Williams, who is the Vice President of International Health Policy and Practice Innovations at the Commonwealth Fund. Welcome, everyone. So, drawing on Kevin's talk then, we wanted to focus these final sessions on actions, what we can do next, and look ahead. And some of the things I picked out from his talk were about complexity. So complexity being used as an excuse to not take action. And he shared the question that I'm sure everyone is familiar with: what is the one action an organization can take? So I'd like to press the panel to reflect on promising strategies you're aware of in your parts of the world. And I suppose those should be strategies that are able to deal with the complexity, embrace the complexity of reducing race inequity. So, David, can we start with you?
Yes. Kevin said, Kevin said, the other one? Kevin said something very important, and he showed data from multiple societies that show that medical care is not the key driver of health. Our healthcare systems, to a large degree, primarily serve as a repair shop that takes care of us once we get sick. They do play a role, but they're not the drivers of whether we get sick or not in the first place. And it's really the opportunities to be healthy in the places where we spend most of our time, our homes, our neighborhoods, our workplaces, our schools, our religious institutions, that determine the behaviors that drive health. And one of the calls then for healthcare systems is, what can healthcare systems do to address the social determinants of health? So Michael Mamet was here earlier and talked about the primacy of the social determinants of health. And there are multiple examples of ways in which healthcare systems can play a key role in driving the social determinants of health. I'll give you maybe just two examples and then let others speak. One is called the Nurse-Family Partnership. It was developed by I think it's a pediatrician, Ken Olds, a physician, Ken Olds in the United States, and the evidence that this works well, he's done 3 randomized controlled trials, taken vulnerable teen pregnant women and sending nurses to make home visits to these teen women that were pregnant. The nurses did routine questions about and support for routine prenatal issues, but they dealt more broadly with the lives of the women. What were their plans? What were their vocational, educational plans? Help them with parenting strategies, and continue the visits 1 year after the child was born. And what the studies show, 3 randomized controlled trials in the United States, what the studies showed is that these home visits, although the knee-jerk reaction of most healthcare systems is too expensive to send nurses to make home visits, these home visits improved health outcomes for the mother, improve health outcomes for the child, improve the socioeconomic well-being of the mother, reduce future visits to the social service system because of problems either needing financial support to maintain herself, produce better spacing of future children, improve relationships between the mother and the father, and that for every person affected, there was literally a savings to society from that approach. And what it took a broader approach than just the traditional medical approach, and understood the pregnancy of that young woman within the broad context of her entire life. And so the data on it is quite strong about what a program like that can do. I'll give you one other quick example. It was developed by Dr. Zuckerberg. He was the head of the pediatrics unit at the Boston Medical Center. The Boston Medical Center is a safety net hospital, so that's a hospital that takes care of people who don't have health insurance and don't have any place else to go. And he developed 30 years ago something called the Medical Legal Partnership. So a GP in the pediatrics unit, pediatrician, can refer a patient to a number of specialists. One of the specialists the GP can refer the patient to is a lawyer. Yes, the hospital hired a lawyer to solve the problems in the lives of the patient. So, for example, a mother comes to the pediatrician and the child has asthma. But the asthma is secondary to the poor housing conditions under which the child lives. All the asthma medication in the world will not help that child to breathe symptom-free if they're going to go back and live in the same conditions that caused the problem in the first place. And the mother who has complained to the landlord and the landlord has done absolutely nothing, it does make a difference when a lawyer calls and says, you have a violation of the housing codes of the state of Massachusetts, we will sue you if you don't fix the problem. The problem gets fixed. So it's just an example of the ways in which lawyers are used. And now you say, well, that's real expensive. When I first moved to Boston 16 years ago, I spent a half a day at the Medical Legal Partnership to really understand how it worked. The hospital actually only pays the salary of one lawyer who coordinates the program and plays a role. But that one lawyer has been successful with working with law firms in the greater Boston area, and some law firms rotate all of their new lawyers for 2 months or 3 months to work at the hospital. There are also a number of law schools in the greater Boston area, and that one lawyer has gotten those law schools to have some of their law students spend time volunteering at the school. So they have a whole program. In the United States today, there are more than 300 hospitals that follow the Medical Legal Partnership model. There are lots of studies published of the benefits of this approach, and it's taking a broader approach to the problems that patients come with, solving not only their medical problems, but providing linkages to other services that could make a difference.
Thanks, David. Yeah, Janet, what do you...
Thanks a lot. I'm going to ask the magic slide people to see if they can find a slide set for me. And basically what I was going to speak to is colonization as an underlying social determinant of Indigenous health. And this is an important thing, and in fact, if my slides magically appear, you'll see that Indigenous people actually all agreed to this. There was a global meeting of Indigenous people in Adelaide while Sir Michael was writing the report on the social determinants of health, but unfortunately, it didn't get uptake in that report, though what's exciting to see is that the conversation is moving a little bit. Right? So the reason why 80% of children are malnourished in Guatemala, right, and there's 7 hospitals for multi-million people, or why in Australia, where there's lots of hospitals, Aboriginal infants are dying more often of sepsis because the hospitals are set up in the settler towns, and we've shown that in Canada too as well in rural areas. If you disaggregate the data between rural non-Indigenous and Indigenous women are 15 times more likely to have to travel more than 200 kilometers to give birth. And the reason why we have this endemic family breakdown where our children, Indigenous children, are taken away from their birth parents, all are rooted in colonization. So there's three things, and there's an article, so another article, a linked article, and an opportunity that I was able to write with my international colleagues, Irma that's here and that we've heard from, as well as Dr. Ray Lovett and Dr. Ricky Harris and Dr. Sarah Jane Payne. We had three things that we wanted to suggest to the readership of the BMJ, and we assume that would be decision makers and clinicians and policymakers. That's not the right set. That was from the last slide set, but you'll find it. And the first thing then is really actually to acknowledge and become familiar with colonization as being the foundational determinant of health, right? Because just as recently as the Social Determinants of Health report was released, that Indigenous direction was ignored and it didn't get uptake in the report, right? So I think most of the people in this room and most of the people online may agree with that. Though often what we hear is that was historic, but it's ongoing right now and impacting Indigenous people. So please become familiar with that. And it crosses over, of course, to the disparities that are being experienced by Black communities and people of color, because colonization was based on a false, scientifically disproven theory of superiority based on skin color, but it's still active. So we need to just accept this, acknowledge it, and if you're going to enter in a conversation about Indigenous health inequities, if you're not talking about colonization, then you're not going to be doing anything that's going to address Indigenous health inequities. The second suggestion that we had, and I think it might link a little bit into the point that we just heard about with respect to learned helplessness, is as Indigenous scholars in this field, we often find this expression and management of sorrow and shame, particularly by non-Indigenous colleagues, takes up a lot of room, and it actually gets in the way of action. And the analogy that we made in the article, like as clinicians and policymakers, right, we have to deal with all kinds of difficult things all the time. But if I was caring, for example, I've cared for many patients over time that have been losing family members to tragic conditions. I've also lost family members to tragic conditions. I can be compassionate, but if I wasn't able to care for the family medically and emotionally because I was overwhelmed with my own grief, I shouldn't show up there, right? So, you know, we hear these apologies. That's great. So then to the next slide, if you can progress, or I didn't bring the, so, oh yeah, that's perfect. Yeah, so we have to support each other. And so this messaging is really for allies to learn to manage discomfort, right? It's very good we're human, and I think here we've all shared some very challenging truths. We've heard narratives. Those stories are key. We need to be compassionate, right? But then we need to process, take good care of ourselves so that we don't become paralyzed, because we have to act. And in fact, it's a privilege maybe to sit with the discomfort and not have to act. It's a privilege that I have. I can go to a therapist and go for a run. It's a privilege that I don't think my mother or my grandmother often had, right? So I think it's really important to stay emotionally connected. But I'm imagining many of you have been in meetings where the whole meeting just gets side-railed or disrupted because there's somebody who doesn't understand their privilege in terms of the processing. And then it all becomes about their feelings of shame and sorrow, which are important feelings and can drive change, but they're getting in the way. If we could just wave a wand and make that get away, it'd be good. Okay, so the third thing is just to follow leadership recommendations and evidence. And so what we said, and imagine that people can relate. And so we've just heard all the 2 days, like what an amazing rich resource. Like I'm going to be looking at all this stuff and right away I can apply it to my life and work. But too often when we're out there, what happens is the wisdom of leaders, you know, leaders like Irma, is just dismissed, right? Or the actual evidence is dismissed because we have colleagues that just know better. They think that addressing anti-Indigenous racism or anti-Black racism is a soft science, right? And somebody told them that this works, right? Community knows what works. The answers lie in our communities, and we need to listen to them. But an example that I'd like to share is, like many people in this room, I've spent a little bit of time trying to figure out in this industry of anti-bias training or cultural safety training, which forms might be the most effective. And I think I'm considered to be somewhat knowledgeable in this field, but I'll have colleagues who, like, are heads of research institutes, and they'll say, well, we're starting a book club, right? And I'm like, well, last time I checked, like, reading books can be good, but it doesn't actually interrupt, like, clinical practice guideline non-adherence that is killing Indigenous peoples in the hospitals, right? And then they say, well, I'm glad you have your opinion, right? So they argue back with me in that way, and I'm just like, well, anyways, I've spent a little bit of time looking at this. So I just wanted to put up this slide, and we really wanted, if you are having, if you feel that you can, it's worth looking at the story of Joyce Echaquan. It's a tragic story, right? But actually, she was able to take out her cell phone and videotape a healthcare team treating her in an incredibly racist manner just before her death, and she went to get help. And in fact, I've written with others on that, and the reason why we didn't show the video is we just didn't have the bandwidth to connect with her family, so we may have something coming out after. But there's leadership recommendations to address this problem around anti-Indigenous racism. And one of the interesting things is that happened in the province of Quebec, and the premier to this day still won't acknowledge that there's systemic racism, right? So the writing that we did, it's just a couple of bad people that do this, but it really does. And again, we've heard about the interaction. So if you can just show the next slide. One of the things I'm very interested then, because if we review the cultural safety literature, one of the things I'm going to do is look at some of the references that Stephanie has, but if you look at the literature about educating people, healthcare providers and trainees, so that they can become more self-aware and more skilled in engaging Indigenous patients and not actually misdiagnose them often as alcoholics when they have a medical problem. It's very weak in terms of its evaluation. So it's a big industry, but most of the outcomes are actually learner focused, and we do need to engage the learners. But it doesn't look at the outcomes like from a patient perspective. So just to say that's a really important area to look at. And then one of the things I've been actively working on, and if you can just show the next slide, is we actually had Indigenous actors go into emergency rooms and family practice clinics 58 times. So we could actually, we had a 3-arm RCT to try to compare the training. So that's just, it's a little proof of concept study that I'm hopefully going to be writing up in the next little while with an amazing team. We got to work with Dr. Patricia Devine and Will Cox, who are some leading anti-bias scholars in the States. But if you show the next slide, then you can see it's underpowered overall, but the we were actually able to see then people that took, the big canoe was an intensive anti-bias training. The little canoe is the one that Dr. Williams has referenced. It's a little bit of a briefer training with follow-up. But you can see then that people with these wide confidence intervals are 5 to 7 times more likely to refer the provider that took the training to a friend or family member compared to placebo. And that's something that's the easiest question to power up. So all the brilliant people in this room maybe can take that, and you can send secret shoppers into clinical practice. It's feasible, it's hard work, but we can start looking at clinical practice guideline adherence. So thank you very much.
Thanks very much, Janet, and hopefully we can share these slides afterwards with the resources. But yeah, without further ado, Jeanelle, would you like to share your strategy?
Thanks very much, everyone, and it's lovely to be here. Thank you for inviting me. So very briefly, I suppose, when we're looking at strategies to reduce inequities in the social determinants of health and promote racial equity, it's quite interesting because a lot of the strategies I worked in, I'm South African, so a lot of resonance in terms of the South African story, but in the UK have worked in the NHS and then have worked in local government, and since October, so worked in local government for 13 years, since October I've worked in national government, which of course is a very interesting place to be at the moment, to learn about politics and strategies. So I suppose I was just thinking how those different environments, we've heard a lot about the NHS and health and care and those and strategies within those organisations, but I think my experience is also thinking about, and Kevin drew on a lot about local government, the political setup in London, and then we've got the Office of Health Improvement and Disparities, which I now co-lead with the Director General in the Department of Health and Social Care, and the strategies there that we're looking at in terms of how we tackle the profound health disparities and disparities in ethnicity, race, and health. That this country is facing. So just a few reflections on that, and I think, first of all, just to be clear, in the UK that life expectancy the good news is life expectancy across the board has increased over the last 100 years, and we know a large part of that has been down to socioeconomic determinants, improvements in where we live, how we live, the jobs that don't kill us quite in the same way anymore, and so on. As well as medical advances. So, the 20% that Kevin was talking about, but then all the other social and economic determinants of health. And actually, there's been a huge amount of advance over the last 100 years. But that's now stalled. In the UK and the US, we're pretty much bottom of the G7 in terms of life expectancy and life expectancy stalling. So I think we really do need to take a serious look at what's going on, understand what's going on, and look at what we all need to do differently. We know that there's certainly disparities in various ways, geography and so on, but also in ethnicity, which is what we focused on here, and complexities within that. And I think the link, certainly in England, between deprivation, geography, ethnicity, inequality or disparities in how long people live and how long they live in good health is all interconnected. And yesterday you spoke, David, about the racial segregation, how that impacts, and I know, Tony, you've spoken about geospatial apartheid and how that impacts. So there's something about place, something about where people live and how they live, and levels of deprivation, and then race, ethnicity within a place. And I'm really interested in that, and what then we do about that. So there's some great work I saw recently by Dr. Rodger Ali. I don't know if others have seen that. But one of the interesting things there, and I think there is some room for hope, is that he was showing that the most ethnically diverse London boroughs that are among the most deprived in London have, since the early 2000s, with the life expectancy below the England average, now find in 2018 a life expectancy above the England average. So something is going on there. We need to unpackage what's different. We need, as he said, deprivation is not destiny. So we need to understand what is going on, what's driven the improvement, so that we can learn from it and apply it. I wanted to focus then on data, which I know across the 2 days a lot has been spoken about. So I don't think it's complex, right? So we have heard about how we just need to improve the quality. I can say more about that, but I think we need the right data and evidence to understand the nature and the extent of the ethnic disparities in health, but also to really be able, Kevin said, was it Kevin? Somebody said in the earlier session, the leaders need, I think it was you, Bola, leaders need to ask the right questions. Was that you? And yeah, in that session. And we need that data and that analysis, but part of that is the questions that are asked of us in terms of that. I think that's so important because my example was also the COVID vaccination, and Bola won't have, Bola articulated that so well, and I was a local director of public health through the pandemic, and that certainly resonated with how we worked in local government with the local NHS, and how data analysis and saying, well, hold on, you haven't shown me where the ethnicity is, what's going on there. We had to ask that question. It wasn't immediately, you missed that bit, Bola, where it wasn't immediately given. That's not how it was disaggregated. Somebody had to ask the question, what's going on? And that came from soft intelligence with people saying, hold on, something's going on here. Then we had the data, then we interrogated it, then we had to drive forward those change in all the myriad ways that you so eloquently outlined. Now that needs to be applied across the board in so many other ways. And the last thing I'll say, because I'm conscious of time, I do think what I've learned so far in my national role is that to convince politicians and policymakers, you have to have the data and the analysis to back it up. And I think that is just the reality. And if there isn't the data, then people can quite easily say, well, there isn't a problem. And actually, the NHS I think the NHS has done that for a long time. It's now recognised and seen that it needs to do things very differently, and we all need to improve the quality of that data and analysis to drive change. But that's true nationally. I think COVID has really enabled so many more people, politicians, senior politicians, to appreciate and understand disparities, including around ethnicity. There is a wave, we need to move it, and we need to move with it. And I think that's really, really important, and that's our role. And going back to the Office of Health Improvement and Disparities, I really see that as a key role for us in terms of moving forward across government departments, because it is about socioeconomics, and we need to change across government, but we need data to drive us forward in terms of doing that.
Thanks very much. And yeah, you're right, we are running a bit low on time, so I think we might sacrifice the questions and answers so that we can hear Reggie out in full, if that's okay.
I'll be rapid. So what everyone else said, and that really reflects a lot of the work I try to do at the Commonwealth Fund. We at the International Program really try to reflect across all of the areas of focus and understand what are some of the best practices, where is the leading evidence and information to show how we can make these changes that we believe are all important. The Commonwealth Fund's approach to addressing health equity, which is led by my colleague Lori, has three major areas of focus: structural changes in care delivery, changing culture, beliefs, and attitudes, and making healthcare services easily accessible to all people. And so we recently commissioned a rapid review of the evidence, the gray literature, major government programs, to identify what are some of the international tactics and approaches that we see in those areas. I just want to quickly sum those up, and I won't get into examples that I have here. It will be published shortly and available on the Commonwealth Fund website, and everybody can see it there. But under the tagline of focus of dismantling racism in care delivery, we found three things of importance. One, something we've heard a lot about during our 2 days, acknowledging and measuring the effects of racism on care. Two, incorporating a wider lens of the causes of racial disparities in health. And three, involving the affected communities more effectively in the governance, health systems, and decision-making that ultimately impacts their care. On to changing cultures, beliefs, and attitudes. We found, one, the importance of medical education and improving the culture of medicine and strategies that go into making that better. Two, consciously intervening at the organizational level. we have to work within our organizations to make that change throughout the organizations. It can't simply be the responsibility of one person. As we heard earlier, you have to thread it through and be the seamstress or the tailor to make sure that things happen. 3, defining and establishing objective metrics, not just to see how you're doing, but to track progress and to evolve those metrics over time as you start to make progress. Finally, bringing about equitable access to care. We've talked about this before, and this is something that we struggle with in the United States, but coverage does not equal equitable access or utilization alone. And so looking at those factors below, the affordability of care, the place where people are, all of those impact that ultimate access to care. And so strategies that are employed to address those become important. And then finally, we say the need to build trust and co-ownership in improving access to care and service utilization. And so how do we work together to build trust? So at a high level, we have 3 areas of focus: dealing with structural changes in care delivery, changing culture, beliefs, and attitudes, and making health care services easily accessible to all. Quick story.
Thank you very much, Reggie. I'd looked at the back of the room to see if there's time for questions. It's a resounding no from Zara, it looks like. Which just leads me to say thank you all so much for coming here. I think, as ever, there's a chance to ask questions on the platform. You can try and grab our panelists after the session if they're still around. I think this is our final panel of the day, so please put your hands together for them.